Okay, it's 12 o'clock. Are we ready, everyone? I'd like to thank you all for joining us today to learn more about long COVID. I'm going to introduce David Kotok next. He is the chairman and chief financial investment officer with Cumberland Advisors. And his company has generously sponsored this important informational educational seminar. And he will then, I guess I should introduce myself, Lynn Annis, Senior Friendship Center. I'm the Director of Lifelong Learning. And thank you again for tuning in. So take it away, David.
Well, thank you very much, Lynn. Cumberland Advisors is a national firm, and we happen to be located in Sarasota, and we happen to support the work of the Senior Friendship Center, which is excellent in its programming of all types on the southwest coast of Florida. In addition to our investment advisory work, we have done a number of economic research pieces on the impact of long COVID, post-viral disease, as it's appearing, and I use the word as it is appearing because we're learning about it all the time. And over the course of that work, for me, I've been able to establish two things. Number one, a working relationship with an organization that Emily Taylor can describe in a moment, what Solve is, what the Long COVID Initiative is, and what her role is, and she will do it better than I will. But we have done a number of these types of presentations together now. The second thing I can say is that in the course of my work as a chief investment officer and our firm's work, we have clients all over the United States. And so part of what we do is talk to them in their businesses or in their organizations. And we're finding long COVID cases, one after another, after another, after another, among the employees and the staff and family members and others among our clients. And so our conclusion is this is something that is really serious and it's really big and it's not getting enough attention. And so it was easy for Cumberland and for me to say to Lynn and to the Senior Friendship Center, we're happy to sponsor a discussion because if it can help some people, that's what we want to do. So our program today is going to operate like this. Emily will introduce herself. She'll tell you what she does. She has a presentation. I believe you'll find it worthwhile and of interest. There's a recording going on. There will be some slides. Anyone who's interested can get them and pass this on to someone else. When Emily is finished, I'll take a few minutes just to talk about some economic impacts of what it means to have a large cohort of disabled people in the labor force. And then we'll go back to Lynn and we'll have a Q&A period and a chat. And we'll make a hard stop after 1 hour at 1 o'clock. So without further ado, my friend and soon to be fishing buddy, believe it or not, Emily Taylor. Emily, let me give it to you.
Thank you so much, David. It's a pleasure to be here with all of you, and it's a pleasure to help out the Friendship Center. I'm so excited to learn more about the great work that you do. I'm sharing my screen. Did that come through okay? Can everyone see?
Yes.
Oh, whoops. Oh,
Oops, but I don't want my
and then I lost it. Okay. How about is it there again?
That's
beautiful.
Good.
Okay, so thank you so much for having me. My name is Emily Taylor. I'm the Vice President of Advocacy and Engagement for the Solve ME and our newest initiative, the Long COVID Initiative. We are a nonprofit organization that focuses in post-viral illness, and we have pivoted to really focus on long COVID because It is a real critical public health crisis. We have been using the term a mass disabling event. And this requires an immediate response, and we're really committed to helping those who suffer. Our flagship programs, as you can see on the bottom there, is the Long COVID Initiative, and we also run data repository called the You and Me Patient Registry. We have over 6,000 people, including people who are sick and controls, in the registry that has over 2 million data points now, that we've published a couple of studies about both long COVID, the impact of the symptoms on individuals, and some of that research is what I'm going to be presenting today. To kick us off, what is long COVID? Long COVID is actually an umbrella term. It's not an actual illness per se. It's not like Huntington's or Hashimoto's or Sjogren's disease. It is actually an umbrella term that encompasses a number of different illnesses, and it is the patient preferred term. It's a term that is truly and holistically generated by the patient population to describe their own symptoms. And unfortunately, a lot of our research partners and our government partners have been really behind the ball when it comes to long COVID. And so most of the research that we have been published by the patients themselves. Patient-led research is phenomenal, and it's really changed the dynamic and made this a very unique disease space because the patients are the ones leading the charge. The more formalized term for COVID, long COVID, which has been adopted by the NIH or the National Institutes of Health, is called Post-Acute Sequela of COVID-19, or PASC. Post-acute sequela of COVID-19. And what that really just means is post-acute, meaning after the initial infection or the acute infection phase, sequela, meaning variety of symptoms, and COVID-19, meaning after COVID-19. So just to give you a feel, you may in your medical settings hear the term PASC, but that is the kind of formalized term that's being applied to the patient-preferred term of long COVID. We're estimating that long COVID impacts about between 10 to 20% of anyone who receives a SARS-CoV infection. And the most persistent symptoms, here's from a little bit from some research characterizing a patient cohort internationally at 7 months. The most common symptoms are fatigue, post-exertional malaise, and brain fog. So one of the interesting things about long COVID is that we don't really have a grasp of how many people have it. There are some studies that show as high as 80% of people who get a SARS-CoV infection experience long COVID symptoms or a long recovery. And then there are some studies that show about 10% of patients that receive a SARS-CoV infection end up with these longer term symptoms. But one thing we can say for sure is that this umbrella term has a couple of key subsets. One subset is people who have been hospitalized because of COVID, and they experience what's called post-ICU syndrome. It's a common syndrome. It lasts for about a year for people who have been in an intense ICU situation, and it takes some time to recover from that, especially in those who have been intubated. The throat recovery takes about a year. So that's one group of patients. We're not too interested in those patients because, frankly, we understand post-ICU syndrome very well. There's another group of patients who are just slow recoverers, people who have COVID symptoms that last for several months rather than several weeks. This is another group that is ultimately getting better, and we're seeing them recover. So they're another interesting subset of the long COVID community, but not the COVID community that we really focus on. We focus on post-infection illness, which is infections or illnesses that have a viral trigger, such as myalgic encephalomyelitis, also known as chronic fatigue syndrome, postural orthostatic tachycardia syndrome, also known as POTS, other forms of dysautonomia, and mast cell activation syndrome, MCAS, just to name a few. This is a family of illnesses that its common thread is that when somebody gets a viral infection, most commonly Epstein-Barr or the flu, but now we see it happening with SARS-CoV-2, these folks never recover from this infection, and this infection triggers a whole new host of symptoms. The three common, which most of which are fatigue, post-exertional malaise, and brain fog, the same three symptoms that we're seeing in the long COVID community. So I'm going to do a deeper dive into ME-CFS because that's actually a very personal to me My mother is one of these patients who has ME/CFS. I have been her caregiver for over 10 years now. Oh my gosh, since 2008. So over 12 years now, over 14 years now. The time flies. And my mother, like many, many patients, is a very classic case of ME/CFS. She got a virus on an airplane in about 2008. She was sick for about a month turned into 4 months, and 4 months turned into 4 years. For 4 years, my mother was entirely bedbound, unable to eat solid food, was highly sensitized to light and sound, and lived in a closed, dark room with her eyes covered and her ears covered. And we brought her in non-solid food for almost 4 years. And that is a severe or moderate to severe case of ME/CFS. Before I move on, I just want to note long COVID's impact on BIPOC communities, or Black, Indigenous, people of color. This is a quote from PBS NewsHour, but this sort of fails to capture the real reality that the people who were most likely to suffer the worst brunt of long COVID and the lack of infrastructure to be able to deal with long COVID are already the poorer and more marginalized communities that were hit hardest by the virus. And we're seeing that play out over and over again, that our frontline workers, our essential workers, were more exposed, and this community has been hardest hit by long COVID because it had a higher infection rate. Touching briefly on ME/CFS. I know this is a very busy slide. You'll have copies of all of these slides to look at on your own time, but I just really want to highlight the graphic on the right with the kaleidoscope of symptoms. What makes ME/CFS unique among diseases is the symptom right at the top there, post-exertional malaise. Post-exertional malaise is a form of fatigue. It's a very complicated symptom to measure, but it's a very simple symptom in its core. What this symptom means is it is a push-crash cycle that the body and the symptoms flare up after exertion or a minimal effort. This can be a cognitive effort, for example, focusing on something, or it can be a physical effort, taking a walk. But what is common about the folks who exhibit this symptom, and it's a sliding scale symptom, it's different for every person, but at a certain point of energy exertion, the person who exhibits this symptom about 24 to 48 hours later will have a complete system crash. And when I say complete system crash, I mean their bodily systems crash. These folks exhibit the symptom after a small exertion or a large exertion, depending on their personal energy envelope. And it is an absolutely debilitating symptom. If you can imagine, one patient I worked with who has the symptom described it as your own personal hell, because what it does is if there's something you love to do, you get punished for doing it. If you love to read and you read a book for a couple hours, the next day your symptoms are worse. If you love to run and you go on a short run, the next day your symptoms are worse. If you love to cook and you take a day to cook your favorite meal, the next day your symptoms are worse. So you can see why this symptom, this particular symptom of post-exertional malaise is so nefarious and so hard to pin down. So I really want to highlight that because that is the hallmark symptom that we're seeing, the hallmark symptom in ME/CFS, and it's also the hallmark symptom that we're seeing in patients with long COVID. So there's a lot of different challenges about ME/CFS, but one thing I will highlight, and I was asked to speak a little bit about helping folks in the doctor's office. Whoops, sorry, too many slides. There we go. Is what our organization is doing about it. We began as a ME/CFS organization. We've been an ME/CFS organization since 1987, and we are the research experts in this illness. We really work hard and fund research, apply research, and look at the research infrastructure. So we consider ourselves a catalyst as an organization. We fast-pace research and discoveries for folks who are in desperate need. So we really focus on patient-centered research, bringing the patients into the center of the research process, and bringing it forward from there. So I mentioned our You and Me registry. That's one of the items that we've expanded. We now have an entire cohort of just long COVID patients in our You and Me registry with, again, over 1.5 million data points that we're pulling together using aggregate data to find patterns and answers about long COVID through that. We also, as I mentioned, fund research. We've increased the size and scopes of our research grants on long COVID with some really cool projects underway, especially around the area of treatment. We're enabling a sustainable infrastructure, specifically with our work around the Long COVID Alliance. The Long COVID Alliance is a collaborative of over 700 patients and organizations that have come together to work on long COVID, and we are one of the co-founders of that initiative. And lastly, I'll have a shameless plug in a moment for our Advocacy Week. One of our flagship programs is we invite members of the community to join us in meeting with members of Congress to share their stories, talk about why this issue is so important. And we do a lot of work, as I mentioned. I'm the Vice President of Advocacy in the congressional advocacy space. So if you're interested in being an advocate and joining us for members of to meet with members of Congress about this issue, to draw their attention to it, we'd love to have you. We're looking for volunteers with long COVID, ME/CFS, or other post-infection illnesses. We're rallying around the two bills this year, the Treat and Care for Long COVID Act. No experience is necessary. All meetings are virtual on Zoom, and we provide you with all the materials you need. We're just looking for volunteers from the state of Florida. So the dates are listed there on the slide. We'll be meeting on Tuesday, May 10th, Wednesday, May 11th for the House, and Tuesday, May 17th from the Senate. If you're available any of these days, we'd love to have you, and you can register at the link there. Lastly, I'm just going to turn my attention to if there's anybody in the audience or watching this at home who actually has long COVID and is really struggling, or thinks you might have another post-infection illness that has been impacting your day-to-day life. We have a lot of resources and support on our website, including symptom tracking, securing your personal support system, finding a doctor, help with work, school, and finances, helping with post-exertional malaise, that symptom I talked about, and how hard it is to manage with pacing, mental health, and of course, for children or teens that have ME/CFS, which is actually a really common side effect of a pediatric infection, especially mono in those young teenagers, is really common for generating ME/CFS. So I just wanted to highlight those resources for anyone who might need them. All of these are hyperlinked. You're free to go directly to them. And there's a picture of our website on the right. I just used a little circle to show where that resources tab is, because sometimes it's a little hidden up there. But there you can see at the top the resources tab for patients and caregivers. And then there's 5 different languages available to translate if there's folks who have other language needs. Lastly, if you are a person with ME/CFS or a person with long COVID and you're having trouble with your doctor, which is one of the most common things that I hear about, in that doctors are sometimes not educated about these particular illnesses, and patients end up educating their doctors. So one thing I wanted to highlight, and this is from our Empower ME or Empower Me program, that really helps when working with your doctor. Just a couple tips and tricks for those who might be struggling with the medical care system at this time. First, prepare your questions in advance. Think about your top 3 symptoms, and then prepare questions that relate to those specific symptoms and present those to your doctor. Think about the top 3 symptoms that are impacting your quality of life. There have been over 200 symptoms documented with long COVID. So that's a lot for one doctor's visit. So instead of trying to talk about every symptom you have, it's really helpful to just zero in on the 3 that are most disabling your quality of life. Bring a list or a bag with all your medications to your doctor's office so that they can see exactly what you're taking. When I say medications, I also mean supplements, any over-the-counter medication that you're taking. The doctors need to see all of that, and that can be really helpful in helping to mitigate symptoms, to understand which symptoms are being treated with which medication. Also, this is sort of intuitive for a lot of people, but for other folks, it's not. Bring a family member or a friend to your doctor's appointment. Even if they can just take notes, they're doing one less thing so that you can be fully present with your doctor and not have to worry about taking notes. So I highly recommend, as a caregiver myself, I've been in many doctor's appointments with many loved ones, and also with other folks that I advocate for. And it makes all the difference in the world to just have another voice in the room that's really speaking out for you. Lastly, one of the things that I really highlight with patients that I think is one of the most common pieces of individual advocacy that can be really helpful, but is another one that's a little bit hard to come by, is using very specific examples with your doctor when you're discussing your symptoms. I've used a couple examples here on the slide of the most common long COVID symptoms and how to describe them if you're trying to describe them to your doctor. And this is something that I see happen all the time, and it's a little tip and trick that can help you make so much out of your doctor's appointments. So the first example for orthostatic intolerance, meaning the feeling of getting dizzy after standing for too long, instead of saying I get dizzy when I stand, which is very vague, say specifically I can only stand for 5 minutes before I get too dizzy to stand, or before I get too sick to stand. That's a really great way of being very specific with your symptoms so that the doctor can really contextualize what you're experiencing. A second one, when we refer to muscle fatigue, I can't even lift a load of laundry. This was a piece of advice I gave to a construction worker who's a veteran who was struggling with his doctors. And I finally told him, you are a construction worker. You could lift 2x4s and pieces of concrete and heavy things. And now you can barely lift a load of laundry. Tell your doctor that specifically so they fully understand exactly what the loss of capability is. Another example, and this is specifically for post-exertional malaise, after a short walk, my symptoms are worse the next day. That's a really common one, and it's to help the doctors understand the difference between post-exertional malaise and regular fatigue, which is, what we kind of experience more commonly, but post-exertional malaise fatigue is a whole different level. So to really help just differentiate those types of fatigue. Secondly, brain fog or neurological challenges. These are really important items to explain exactly what that brain fog looks like. Saying I'm confused a lot, that's not going to give your doctor the context they need. Right. So things like about 3 times a day, I can't remember my address. That's a really important symptom, and framing it in a way that the doctor can understand exactly how there's neurological complications there. Lastly, pain. I have to take a moment to talk a little bit about pain because pain is a very complex, nuanced symptom that I see patients who struggle with pain really struggle in communicating with their doctors, and that lack of communication means that they're not getting the pain medication or the pain support that they need. So I added this example about how to describe pain. Of course, there's always the first thing, the location of the pain. Start with where the pain is most concentrated, but it can be in other places as well. So in this example, I said the pain in my shoulder joints, but that could be all your joints, that could be your knuckle joints, your wrist joints. So be specific about where the pain is originating. And of course, use the pain scale. The pain scale is 1 for the mild discomfort and 10 for the worst pain you can imagine. So use the pain scale when discussing your pain to describe exactly how severe it is. And then also describe if the pain is moving or stationary. Is it always there, or is it only there when you move certain parts of your body? Is it a muscle pain? Is it a joint pain? Is it a stabbing pain? Is it a neurological pain? What kind of pain is? I use the example of a pulsing pain that radiates out in this example. So this wanted to really focus, because this is something I see patients struggle with a lot when you describe pain. There's a lot of nuances to describe pain, and I really encourage patients to be very clear with their doctors about the location of the pain, the quality of the pain on the 0 out of 10 scale, and then where the pain moves or doesn't move. Is it stationary, or and then also what kind of pain? Does it radiate? Does it pulse? Does it throb? All of those are really important elements to talk to a doctor, and I love trying to help patients communicate better with their physicians because it really does change outcomes. So with that, I know I went a little bit over, my apologies, but that's a overview of long COVID and the different symptoms that will likely appear if you are struggling with long COVID, and how some examples of how to work with your doctor if you are struggling with those symptoms. And with that, I'm happy to turn it back over to David.
Question.
Please.
So, do we interrupt with a question now, Lynn, or shall we do that for a moment or two? Maybe Emily can take a spontaneous question. In fact, while you set that up, let me just ask Emily to add a few things. Emily, mention long COVID clinics and how people find them. And in the state of Florida, if I recall correctly, the estimates are there are about 500,000 people out of 22 million who have versions of long COVID. And maybe the last one is, if you had COVID and it was a mild case, that doesn't mean you're out of the woods when it comes to long COVID symptoms. So could you address just those and then maybe let me make a word or two about what this means economically for the country?
Absolutely. So I'm just pulling up real quickly. Let me see if I can share this. This is a map from one of our partners called Survivor Corps of the post-COVID care clinics in the United States. Here we go. So almost every country or every state in the country has a post-COVID care clinic. Here in Florida, you can click on Florida and get a list of the post-COVID care clinics that are available here. There is one downside to post-COVID care clinics. While about hundreds of them have popped up all over the country, there is no standard for what makes a post-COVID care clinic. So you might get 100 different services from each different clinic you go to. So I advise you to be very cautious when you approach your post-COVID care clinic and use those principles I shared about using a doctor. And one of the things I'll just add is that some of these clinics are simply referral services that just refer you out to other specialists. Some of them are real experts that know exactly what they're looking at. So I would just advise, if you are looking at a post-COVID care clinic, ask if they've treated post-viral illness before COVID, see if they have some experience with other post-viral illnesses. And that's a great way to gauge if that's a post-COVID care clinic that can truly treat your symptoms. Secondly, I'll just add, speaking of Florida specifically, I'll share my screen again here. This is the numbers for Florida based on our recent white paper that we just published a few weeks ago. The cumulative cost, meaning the cost to patients in Florida, that's not the cost to the community, but rather that specific cost to patients in lost wages, lost savings, and increased medical care costs as a result of their long COVID infection. So that's about $30 billion for the state of Florida. The percent of the population currently with long COVID in Florida is 7.9% of the population, with about 2.6% of the population having disabling long COVID, meaning a long COVID that's so bad that they are unable to continue to work at their pre-infection levels. That's how we defined disabled long COVID. So that group of disabled long COVID is 544,000 individuals in the state of Florida, culminating in about 2.6% of the total population. So sorry, David, remind me of the last piece of your question again. There was the clinics in Florida, well,
you gave the numbers and you inserted the costs, and that's helpful. Someone I saw just wants a quick question, so we can get to the questions. Let me just make 2 quick points and then let's give it back to Lynn for questions. Point number 1, and no criticism of Emily, fully vaccinated people are 50% less likely to get long COVID than unvaccinated people who survived COVID. Am I about right, Emily? It's about 50%.
Actually, it's a little higher now. A recent study from Israel found that it was a 66% reduction in the likelihood of long COVID as a result of vaccination, fully vaccinated.
Okay, so the next point is, in the state of Florida, we have a population of people who are not vaccinated. And what that means is, among the large population that is not fully vaccinated or not vaccinated at all, or is drinking what I call the disinformation Kool-Aid, they are double the chances of having long COVID symptoms. That's my first thing. The second thing, just the economics of this, is that if you look at studies like that recently done by the General Accounting Office of the United States, which estimated the numbers in the millions of long COVID, or you look at the labor force statistics, and you find today in the United States, there's 11 million job openings, but only 7 million people in the labor force looking to fill them. Why? There aren't enough people. There aren't enough people for three reasons. One, we've had 1 million excess deaths from COVID. And most of us now know at least one or two people who are no longer with us because of COVID. I know several. Some of them were in the labor force and working, and they're dead from the disease. What we have to remember is for every one that died, there's 10 or 11 or some number like that who are disabled from long COVID. And because it's not a visible disease like polio, we don't see it, but they're there. In the Senior Friendship Center, we know of such cases. That was part of the original motivation to try to have this session. And lastly, when it comes to disinformation, you heard Emily describe POTS, a very specific type of post-viral disease symptom. When the disinformationists go to the federal website, which records the recording of every single reaction to a vaccination, they say, oh, look, somebody got vaccinated and they got POTS. It's the vaccine's fault. And they're lying to you and to me. And they are essentially contributing to more cases of death, disease, hospitalization, and long COVID. So disinformation is now a serious risk for us. And it's operating because it has monetary interest behind it. They sell subscriptions and snake oil treatments and other things to get money, and they don't care about what they do to people when they do so. So we have these forces at work which counter public health. Our expectation is that long COVID will have 2 to 3 million disabled people, either partially, temporarily, or permanently disabled in our labor force, which means labor force shortages will be with us for some period of time. And when you have labor force shortages, you have several other secondary effects: rising wages, inflation outcomes, difficulty in full staffing. And these are the kinds of things that we see in the economy and in our market-based economy all the time. So let me turn it back to Lynn, because I know there are questions. And Emily, why don't we have a few minutes. We can have a Q&A with anybody who's interested, either one of us.
Hi, I'm interested. May I ask a question?
Yes, please, welcome.
Okay, my neighbor got COVID. He said, oh, it's nothing, 3-4 days, it's over. He goes out fast walking, lifting, running, and darn if he doesn't get a blood clot, goes down on the ground, has a stroke, and he's paralyzed on one side. What we understand is once you have COVID, you should be on a baby aspirin every day because COVID thickens the blood. So he's running out there with this thick blood 3 days later. Why? And I asked the pharmacist, she said, of course, everyone who's had it should be on a baby aspirin if they're not on a blood thinner. Why aren't all the doctors prescribing this? Thank you.
That's a really important question. Thank you so much. You're describing the recently documented phenomenon, which is called microclotting, which is exactly as you describe, a microclotting in the blood that thickens the blood and does increase potential for stroke risk. And it is shown in folks with COVID, and it is specifically a factor of long COVID. So that is absolutely accurate what you're describing. We're still sort of peeling the onion research-wise about why that is and how that is. We don't really have enough definitive scientific evidence to show the exact directive of these two things next to each other. But I highly recommend, if you've experienced a COVID infection, whether it's asymptomatic or mild or severe or hospitalized, it's very important to continue follow-up care with your primary care physician, and they should be checking for microclotting. Now, let's be clear, not everybody necessarily gets microclotting. This is a phenomenon that we've observed in an elevated portion of people with COVID, but not everyone. So to say everyone should be on baby aspirin, that might be a little too premature, because it's not everyone necessarily who gets the microclotting reaction. However, it's a very simple test in your doctor's office. And so if you do believe you have long COVID, or as you described with your neighbor, someone who got COVID and recovered, you should still be getting regular testing at your doctor's office if you're looking for these follow-up factors over the course of months and years following your infection, to make sure you're identifying these potential bad behaviors of your body that can come out of those COVID infections. And one of those can be exactly as described, microclotting.
Yeah, I haven't had COVID, but I still take a baby aspirin every couple of days, because they say you could have had it and not know it. And the baby aspirin isn't going to hurt me. So I wish you'd get that information out to the doctors across the country. It's unbelievable.
Absolutely. Well, we are working closely with the CDC and NIH on some of their technical expert advisory panels. But the one thing I will add is, I will just say, this is my personal opinion, I'm overall very disappointed with the reaction of the NIH, the CDC less so, but our government entities have really been approaching long COVID with this attitude of, this is so new, we've never seen this before. And that's really problematic, because we know some of these risk factors and some of these dangers, especially for folks who have previous autoimmune conditions or previous diabetes or certain other factors that make you more highly susceptible. So we really are very concerned that the attitude of a lot of the researchers and government figures is not taking into account the information we already know about post-infection illnesses. For example, we already know about post-exertional malaise. We already know about reactions of the body and the immune system, and we're not using that information to apply it to people with long COVID. We're acting like long COVID is something new, which is, I think, a very damaging perspective, because we could be accelerating the science a lot faster if we started with the research we already had.
Thank you.
Thank you. It was a great question.
Next question. Lynn?
I don't see one in the chat, so if anyone has one, they could just speak up.
So while we do that, let me just ask Emily. Emily, in the Congress and the Senate, only one member has admitted to long COVID, and I believe that's a senator who has helped sponsor the national piece of legislation. But we hear there informally that there are a number of members of Congress, but they don't want to admit it because they're afraid of political retribution. Am I right about that?
That is 100% right. So the one senator you're referring to is Senator Tim Kaine from Virginia, who has been very public about his long COVID symptoms. He says that he is experiencing what he calls a heat pad effect, where different patches on his body will start heating up randomly without any seeming cause. And he says it's a very disturbing symptom, but it's a very non-disruptive symptom. He says he can still work, he can still function. So he would be what we would call a non-disabled long COVID person, someone who's experiencing strange symptoms as a result of their COVID infection, but is not disabled from work. That, of course, is not applied to everybody, but as we know, there's other members who have alluded to the fact that they have experienced long COVID, but are not public about their symptoms.
We do have a question now. This is to Emily and David. How are you dealing with traveling on airplanes now that the restrictions have been lifted? I feel like the government is letting us down when it comes to our safety. The CDC seems to be losing on every level.
That's an important question. So personally, if I'm planning on traveling in the coming months, and I'm planning on being 100% masked and continuing regardless of the CDC guidelines. One joke that I heard, which is sort of a gallows humor joke at the early stage of the pandemic, is they said when the restrictions start lifting, it doesn't mean the problem is gone. It just means we have room for you in the ICU now. And that's sort of the reality, is these restrictions are based on hospitalization levels to whether or not we're overwhelming our hospitalization infrastructure by having too many people sick and in the hospital at the same time. So basically, you'll see these restrictions start to alleviate, meaning that essentially our hospitals are no longer overwhelmed and we have room for you in the ICU now. So if you want to continue using masks, I highly recommend it, especially, again, I have to emphasize, if you're immunocompromised or had a history of diabetes or other autoimmune diseases, you are more highly susceptible to long COVID than others. So again, mask up, don't touch your face, sanitizer, and washing your hands regularly. Those are the best things you can do. And I personally have just chosen to not eat indoors. I only eat outside now. You know, just certain adjustments that you can make to your own level of risk. As I mentioned, I have my own mother at home who is a person with ME/CFS, and she is immunocompromised. So I am very overly cautious because I know that I am her lifeline. And if I get sick or if I bring sickness home to her, then I'm really putting her at risk. So I consider myself the front line of defense for my family. And I'm the one who goes out and does all the shopping and brings it all home. So I'm always masked and always hyper vigilant, but it really is to your level of comfort.
And I have a question here from Virginia.
Yeah, well, I did get COVID from being on an airplane and I was masked, but other people weren't. This was almost a year ago. Since then, I had to go on a plane, so I wore a mask and a shield.
Mm-hmm.
Has it been shown, I mean, I have to go on a plane in a couple of weeks. Has it been shown that the shields actually do help with, as well as the mask, with protection?
That's a great question. I have not actually seen the research myself. I'm sorry, I just haven't looked in that area specifically. But my understanding is that shields or just glasses, anything that protects your eyes from receiving airborne particles, is very valuable. Again, you have to treat this like it's airborne. It is airborne. So the full mask, making sure that you seal around the cheeks and under the chin, that is a full seal. And then obviously the shields that go fully around your face. I personally use my eyeglasses as a little bit of a shield, but I recognize they still have gaps on the side. So a full face shield that has the what they call the seal is critical.
Great. We have another question here. This one's from Norm. Some basic precautions for cold and flu season seem to have surprised people since the pandemic start. We can probably surmise that some spikes in past cold and flu seasons are from the same people that refuse to acknowledge the positive role in mitigation step. Emily just gave a quick recap of common sense steps, and none of this is new. So that was basically an observation that Norm had. Do you want to comment on that?
I would just add to David's point earlier that long COVID as a result of a COVID infection can happen from any type of COVID infection, whether it's asymptomatic and you didn't even know you were sick, to whether you were hospitalized and in the ICU. It can really, the rates of, what we're finding is the rates of long COVID are pretty standardized regardless of severity. However, the severity of long COVID is worse based on severity of the illness. So the more sick you were, the more likely to have severe long COVID, but the likelihood of long COVID in general is pretty stagnant across all the different types of infection and severity of infection. And this is actually very consistent with a couple of our theories about what causes ME/CFS. We believed before the pandemic that what ME/CFS was like a switch in your neurological system that got flipped to sick response. And for some reason, even though the virus had already been, the acute phase of the virus had already passed, the sick response switch is still flipped. And we can't unflip it. We don't know why people are still responding like they're sick, even though the virus itself seems to have left their system. So there's a couple of theories about why that is, but it really comes down to exposure to these pathogens, whether it be SARS-CoV-2, influenza, or a regular cold. It all carries a risk of flipping that switch in your brain. And some people have a natural immunity to that. In fact, men tend to have more of an immunity than women to some of these post-viral illnesses. In fact, post-viral illnesses are at a prevalence of 4 to 1 in women compared to men. And this actually is a direct link to, if you remember your high school biology and the Punnett squares that you would draw for sex characteristics, the 4-to-1 ratio is there's 4 squares. So 1 would be your negative recessive alleles, and then the other 4 have the positive demonstrated alleles. And you can see that there's specifically in women's immunology and the way that we respond to these pathogens, we are more likely to get longer terms of sickness and more likely to get post-infection illness. So it's really a fascinating area of science that we're kind of uncovering as we go. And I truly, truly believe that this research, that if we do it right, the research for long COVID is going to unlock all of these illnesses and really help so many people, millions and millions of people, get back to health.
Thank you. We have another question. Could you elaborate more on COVID brain fog?
Absolutely. So brain fog is a terminology for a general symptom of cognitive disruption, that when you feel fuzzy, it's kind of like when you first wake up in the morning and your brain is just the hamster on the wheel is not running as fast as it usually does. I've had patients describe how they forget their own names at times when the brain fog is happening, and they feel their brain is lost in the moment. And it comes and goes, and it can be hours long, interrupting your entire day-to-day life, or it can be moments long and just be a transient experience. So brain fog is a form of cognitive disruption that that is generally referred to as this fuzziness. What that specifically means for COVID brain fog. So for those of you, I had COVID myself a few months ago, or a few weeks, about a month ago. And I noticed when I was in the thick of it, when you had that high fever, how your brain just couldn't process the stimulus around you. Like I felt overstimulated by a TV show that was pretty benign because there was just too much information and input just from a simple TV show. So that's sort of a description overall about what brain fog as a symptom looks like. It can have a lot of different causes. Specifically, what long COVID brain fog is the most common symptom reported. And what I'm seeing or hearing from patients that I speak to about their experience is that the brain fog is tends to be, and this is anecdotal information, tends to be more permanent or more long lasting, which I've noticed with patients with COVID as opposed to patients with ME/CFS. The patients I've worked with for decades with ME/CFS tend to report that brain fog comes and goes with their other symptoms. Whereas what I've heard for the COVID brain fog is that it tends to be more lurking around, and it doesn't quite come and go with the same frequency. It sort of just stays. And that's one of the most disruptive symptoms that I've heard from a lot of patients, is the inability to think clearly.
Yeah, Emily, I wonder if you could say a word about the progress of treatments and the development of treatments for long COVID in its various forms.
Absolutely. So this is another area where I'll share my personal opinion that I'm pretty disappointed with the government agencies at large, because I don't think the focus is on treatments enough. A lot of our government research is looking at basic science, the starting from tabula rasa, like why is this happening this way? And I think we can fast forward that to look at treatments. Specifically, the #1 treatment that I recommend for all of my post-infection illness patients is pacing, pacing, pacing. This is the treatment which is basically modifying your day-to-day life so that you exert only as much energy as you have, and you avoid those crash cycles that I described before. So this is for people with post-exertional malaise. And it really means, unfortunately, cutting a lot out of your life and saying, I only have enough energy to do 5 things today. And those 5 things are going to be take a shower, play with my kid, eat dinner, and do a little bit of email or whatever. And that's sort of a description or an overview of what pacing looks like. It's unfortunately the treatment of limiting your energy expenditures to only what's most important and keeping yourself within that limit of your energy envelope. I know one patient with post-exertional malaise who wears a wrist monitor that monitors her heartbeat. And anytime her heartbeat goes above 120, she has to stop what she's doing immediately. And unfortunately, because of her other symptoms, that can just be standing up and walking to the refrigerator can make her heartbeat skyrocket that high. So she has to be very careful, and just, if her wristwatch goes off, that's it. She's done for an hour. and she has to sit down and rest. So it's a very disruptive symptom, but I'm glad you gave me the opportunity to share a little bit more about how folks can manage it. Speaking of pharmacological treatments, there are a number that have a lot of potential, but none of them are approved by the FDA. So if you were going to take them or look at them, you would be taking them off label. And I highly recommend you talk to your physician about taking any such pharmacological treatments in advance. Some of those include the drug Ampligen, some antivirals. The other anti-inflammatory treatments can be really helpful, things like prednisone, which is a very dangerous drug in itself, but these are examples of some treatments that can be used. But again, speak to your doctor first, because you're treating the symptoms with off-label drugs, not necessarily the underlying problem. And lastly, when it comes to treatments, the other thing I'd highly recommend is this is something that my mom and I have both adopted and I have had a lot of success with. It's called the IC diet, or the intestinal colitis diet. It's an anti-inflammatory diet. And for those with ME/CFS or long COVID, or really any of the post-infection illnesses, inflammation is a huge problem. We've even been able to document that the inflammation goes as far as being inflamed inside of the brain, and the brain starts swelling and causing huge symptoms as a result of that action. So there's actually a lot of things you can do with your regular diet that just tones down that inflammatory markers. Things like avoiding anything in the nightshade family, tomatoes, onions, anything in the nightshade family causes inflammation, avoiding other certain acidic foods. And you can just Google the IC diet, I as in igloo, C as in cat. And I highly recommend that diet as a very first step for folks who are experiencing inflammation or pain as a result of inflammation, because for my mother, it really helped change her.
You just did away with my marinara sauce.
I know, I'm sorry. I love it too.
All right, Lynn, any other question?
Yeah, Virginia has another one.
Well,
Here.
I had a comment which you covered well by the inflammatory response, because the stress and the cortisol release then has the brain inflamed, which then causes the brain fog, because I do a presentation for caregivers about brain fog and why they have brain fog. So that it's that whole stress release. So anything that can reduce stress, whatever people have access to, exercises, all of that. Has there been anything that shows that it may be anecdotal, but that has helped kind of camp down a little bit the cortisol release with stress?
It sounds like you are really informed on this topic, so I'm going to share. I highly recommend you Google a researcher. His name is Dr. Jared Younger. He's out at the University of Alabama, Birmingham, and he's done an entire fleet of studies on the different types of brain inflammation and different ways to bring it down. He actually found that cumin, that that spice that you use on your chicken, is actually really effective in reducing in neuroinflammation, and some other over-the-counter supplements. Highly recommend his research. He has a whole litany of different kind of unexpected regular treatments that actually do help with brain inflammation.
How do you spell his last name?
Younger, Younger. Yes, Dr. Jared with a D. From University of Alabama, Birmingham.
Okay.
He has some amazing research in this area. Highly recommend. But the one thing I'll just flag, so the most studied area of post-exertional malaise treatment is unfortunately exercise and cognitive behavioral therapy. And both of these treatment programs, graded exercise therapy and cognitive behavioral therapy, have been shown to be pretty much ineffective. So especially with graded exercise therapy, I warn a lot of caution to my patients who want to try graded exercise therapy, because it can cause harm. If you push too hard too quickly and you push past that energy envelope, you'll actually be worsening your outcomes, not improving them. And I say the same thing to my patients who are really eager to go back to school or back to work. I tell them, wait till your body tells you it's right, because if you push too hard too fast, you'll be triggering that crash symptom, and then the harder you crash, the more you crash. So it really is this sort of what's the word, this kind of spiral, like a flywheel, and you have to slow down the flywheel, which means slowing down your activity in order to prevent it from spinning up and getting the symptoms from spiraling out of control.
Lynn, I think we have about 5 minutes left if there's another question.
Yes, if anybody has one, just unmute yourself and ask David or Emily. Christine, do you have a question? Well, I have a question. When is this all going to be over? That's what I want.
Let me try that one. So I'm in the process of writing a book. That book has involved the research of epidemics and pandemics for the last 3,500 years. The first record of an epidemic, a plague, was in the ancient world 3,500 years ago. And there are written records since. And what I've observed in preparation for the book is that it isn't over until it's run its course. And that's true whether it was a plague or smallpox or some other viral disease. That's number one. In my opinion, history would suggest that the COVID pandemic, which is raging in other places in the world, is not over. It can't be over until you can look around the world and not see it raging anywhere. That's the first thing. The second thing is we're all impatient. We have COVID fatigue. We want it to be over. And when we let our guards down, which unfortunately means masking or no masking, do I go inside a crowded building or do I avoid it? What do I do? When we let our guards down, we give the virus the chance to, one, spread more, and two, that encourages mutation. And a virus only wants to mutate and mutate and mutate to find some other way to infect somebody. That's its natural, it doesn't think, it just mutates. It will mutate 1,000 ways, and it will try to find the one that can get to you or me, because that's what it's all about. And until it runs its course, each of us then has to face a choice. What do? How do we get curated, trusted information in a society which now permits and encourages disinformation? I'll give you an example. There are 8 cases of polio, and some of us may remember when President Eisenhower and Jonas Salk launched a national American vaccination program to defeat and eradicate polio. That was 1955. It hasn't been eradicated. Why? There are several countries in the world where it is endemic, and there are cases that are moving around, and some of those cases are now infecting new people. And there are 3 different variants of polio, not the original polio from years ago. There are 8 cases of polio that were identified recently in Israel. The Israeli medical system is very public and transparent. They weren't vaccinated because there's a whole world that is not protecting itself, a whole piece of our world. And therefore, that's a risk. Now, we don't have polio cases in the United States today, but we have a large population. that isn't vaccinated and isn't protecting itself. What does that mean? It means one can say that's possible in the future to again have polio in the United States. I would submit before we close that if the 10 million people who have post-COVID disability, and we've just talked and had descriptions about some of them, if they had polio and we could see them, the behavior in the United States would be totally different than the behavior that we are seeing. And that's what, therefore, requires each one of us to have to make decisions to protect ourselves and the people around us and the people we care about and the people in our businesses and in our relationships and in our organizations. And that's where we are. So I'm sorry to say, Lynn, I don't think it's over. And I think there's more coming. And unfortunately, the impatience and fatigue from COVID will invite it to get here sooner. But the Senior Friendship Center at least is providing a forum, and we're happy to support it, to try to have these conversations. I don't know if people on the conversation felt this worthwhile, but if they did and they want to hear more of these kinds of things, Lynn, maybe they can advise you and we can do other programming. As for Emily, you are doing terrific work. Please keep doing it with your organization. I see a hand up. Maybe we have 1 minute.
Betsy White.
I don't know how to do this. Can you hear me?
Yes.
I want to know if most of the physicians are now approving the newest booster for those who have had all of the other boosters and the original vaccine. Are they
That's a great
suggesting?
question.
Are they suggesting that most of us who have had no problems this far really should go ahead and get the newest booster?
Yes, as I understand it, anyone age 50 or older and anyone who had a previous autoimmune condition or had been consulted by their doctor that they've been unable to uptake the vaccine, so that's people with autoimmune or immunological compromise, those folks do need to get the fourth booster, and also anyone over 50 is approved to get the booster. So for example, my brother is also a person with chronic illness, and he's only in his early 40s, and he also went and got the booster as well at the recommendation of his physician because of his immunocompromised status.
Thank you.
Well, I want to thank Emily and David for this wonderful opportunity to learn more about long COVID. I mean, this was just very enlightening to myself to learn all of this, and I'm sure everyone feels the same way. I mean, we're so appreciative of this. Thank you.
Truly my
Nice.
pleasure. It's a joy to work with you, Lynn, and of course, David, anytime I can do a presentation with you is always fun.
Be safe, everybody. Thank
Yes.
you.
Stay safe. Thank you. Bye.
Thank you. Bye-bye.